the subjective. There's somebody just saying, oh, it came on all of a sudden. I was kind of sick. I had a respiratory, whatever. And this came out all of a sudden, this awful vertigo, and it's just been kind of just tapering off since then. I feel off balance, whatever. When I turn my head, I get dizzy. That sounds more like a hypofunction to me. If somebody's like, I laid down in bed and everything was spinning like crazy, and then it stopped after like 30 seconds to like a minute, and then I was back to normal again, like that sounds so much like BPPV. All these provocative head positions like laying down, tying shoes, looking up into the top shelf, that's all like moving those anterior and posterior canals, because what BPPV is, as you guys know, is our calcium carbonate crystals are out of place. We all have them, and that's normal, and that's like how we balance and have inner ear function to help us balance. But if any of those little rocks, those little crystals, like make our way into the semicircular canals, and every time we bend over and move, they move in the canal, and they say, hey, you're spinning around in a circle, and so your eyes are doing that until it settles. That's why it's only for a few seconds if it's canalithysis. So the first test that we'll go over is called the Dix-Hallpike test. They have it on here as the Hallpike-Dix. People refer to it as both. It doesn't really, I don't know many people who call it Hallpike-Dix, but it doesn't really matter. And they're doing it one way where the therapist is kind of in front. That's one option on how to do it. I'll show you another option on how to do it as well. Both are correct. The other option I do because if this person is positive, then that's how you. I was going to use that stool. That's the position that they need to be in anyways to get treatment. So if you're forward and you lay them down like this, guess what you have to do the Epley maneuver? You have to come around and sit here to finish the maneuver. So that's why I just do it the other way first. And if I'm testing the Dix-Hallpike, which canals am I testing? Anterior and posterior. And if my head's turned to the right, am I testing the right anterior and posterior or the left? The right. The right. Yeah, and the left, if my head's turned left. So, can I use you as my patient? You don't feel dizzy or nauseous or anything? Okay. All right, so first part is having the patient sit exactly, with their legs out. Oh, don't lay down yet. And then you want to make sure that they're on the right place on the table. So like if she laid down right now, she'd be too far down this way and her head would just lay flat here, which you don't get the cervical extension that you need for the Dix-Hallpike test. They need 20 degrees of extension, which I've already set up my handy dandy table, declined in that degrees, in those amount of degrees, but that means I need her neck to be about right here so that she can rest her head on that table. So yeah, that's kind of the first part, even a little bit more forward. There should be good, yeah. And then which side you test first doesn't really matter, with the exception if you know or have a hint of what side it's on. So believe it or not, I do have a hint a lot of times because either their physician found it on one side or the patient has had it before in their past and they're just like, oh, this always happens in my right ear. It doesn't matter, we're going to test both sides anyways, but what I usually will do is try to test the side I don't think it's on first so we can clear that, get a clean test result for that, and then go to the other one. And then if it's positive, I could just go straight into treatment and I have more information, versus if I test this positive side first, I'll just go into treatment, I have no idea what's happening with the other canals. So, all right, so for this one, I'm gonna have the patient turn their head to the right, and then on the count of verbal cues, you wanna keep them pretty minimal. All I say is on the count of 3, I'm gonna have you lay back, please keep your eyes open. If it's a positive test, you'll experience that vertigo dizziness. So On the count of 3, we'll lay back. Please keep your eyes open. 1, 2, 3. Good. That's even a little bit not extended enough, so I'm just going to lower just a little bit. There. So I'm going to make sure you get enough cervical extension. And here, you're observing the eyes for nystagmus. If you doing okay?
Yeah.
Okay. So if it's upbeating nystagmus, which canal is involved? If the nystagmus is upbeating, you can sit up. You can sit up. Yeah. You're okay. So if the nystagmus is upbeating, it's your posterior canal that's involved. And either way, this should be torsional. It should be twisting and going up. That would be posterior canal. Some people say all kinds of things to help them remember it. Posterior up, pup is up, different things, but it's basically going towards the posterior, the actual posterior canal. If it's twisting and going down, downbeating, that's anterior canal. So because her head was turned to the right, we would know that it's either the right posterior going up, the right anterior is going down. So the next thing I'm looking at, once I have that information, is how long does the nystagmus last? And this will tell me if it is canalithiasis or cupulolithiasis. So most, and just so you guys know, anterior canal involvement is like 1% or less of cases. Posterior is like more than 80% of cases. So if you're in doubt, it's probably posterior. But people go their whole career without saying anterior. The treat vestibular problems, so it's very uncommon to have anterior. They don't say that anywhere in this course, but I feel like you guys should know that. So the next thing is time frame. So if it is less than 1 minute of nystagmus, then it's canalithiasis, meaning the crystals are free floating in the canal. That means they're free floating and they landed on the curve after a few seconds, anywhere from 1 second to 59 seconds. It's not close. It's not going to be borderline. It's going to be like 1 or 2 seconds to like 30 seconds most of the time. It's going to be nowhere like, oh, it was 58 seconds. I don't know which one, like it's usually very short term or not short term. So then I know that the full name of the diagnosis is right posterior anterior canalithiasis. That's what I would say. And that's part of the practical too. I'll say, what's your diagnosis? Right posterior canalithiasis. So you're saying the side it's on, you're saying the canal that's involved, and then you're saying the type, canalithiasis or cupulolithiasis. If it lasts longer than 1 minute, that's the other one, it's cupulolithiasis. That means it's looped all the way around the other side of the canal and stuck to the wall, and the nystagmus is not stopping. It's lasting longer than a minute. It may not ever stop, but once you're crossing over the minute mark, then you're like, all right, I have enough. This person's not loving life right now. I can stop what I'm doing, sit them up, because I already know it's right posterior, anterior, depending up or down. Cupulolithiasis. Does that make sense to you guys? Yeah. Okay. So all that same thing on the left side. So and honestly, I had you not far enough down, so you were right. Yeah. So I'll show you the left real quick.
Do you notice like the onset time too when you're doing it?
Yeah. So what is textbook is that you will have a latency period which means it takes a second or two to start if it's canalithiasis, and you won't if it's cupulolithiasis. I usually don't. I mean, you're absolutely right, but you don't need that information. Like, so that's even hard. That's hard to tell if latency is usually 1 second. So it's tough to tell, but that is true. Cupulolithiasis should be immediate, and canal should have a slight waiting time.
But like real life, usually not the case.
Yeah, I'll sometimes see it like it's usually 1 second. Yeah. I've seen it for like up to 10, 15 seconds, and those are weird cases. But so, which brings me to another point. That's a really good point. How long do you hold them there if you're not seeing anything at all? A minute. Yeah. You gotta just hang out for a minute and just see. Otherwise, you could be getting a false negative. So, all right. So real quick, what you guys will see to the left side. So, all right. So I'm gonna have you turn your head to the left, and then on the count of 3, we'll lay back. Please keep your eyes open. 1, 2, 3. Very good. So I have her head turned 45 degrees. Her neck is extended 20 degrees in extension. And I'll give you guys a fake test results. So right now I'm seeing upbeating nystagmus that lasts 10 seconds and then it stops. What's my diagnosis? Yep. Left posterior canalithiasis. Yep. Very good.
Are you supposed to hold the head too?
You don't have to. Like if you have this, a lot of people, and you'll see it in pictures and stuff, like even in your lab manual, like they'll just go, the other option of how to do this is head off. Like you're just holding their head in space. And you could sit up, I can show you as well. So on massage type tables that don't have this function, on a table like that, you would basically just have their head extended off into air, and it would just be in your hands, and your elbows would be on your thighs, so you're supported there. I used to do it that way, and now I started using it this way. I get better results this way because the patients don't like this. A lot of people have kyphosis and other stuff that this happens more commonly to older people. So it reduces guarding if they can put the back of their head on the cushion versus if you're just like holding them. So I also don't go too far away. I don't go hands off because I don't trust people because they'll move around. They don't know what you're trying to do. I had people that are like, oh, let me fix my hair. They'll like move around, and it's like, no, you can't do that. So I usually will at least put a hand on them just so they stay in place. Sometimes people shut their eyes because they don't like the way it feels, and I like, to be honest, I straight up just pull their eyelid open.
Oh no.
They'll, believe it or not, they'll hate you less if you do that than if you tell them, sorry, I gotta do it again, because I didn't see anything. So I've never once been like, why'd you pull my eyelid like that? I just tell them, sorry, I don't want to do this to you more than once, and they always understand. So yeah. Stick I'm wearing gloves, but I like use my thumb and I crank their eyelid open. So yeah. All right. So we will break out and practice the Dick's Hallpike test real quick. 1, 2, 3.